Good morning and welcome. I am Eboni Price-Haywood, a general internist at Oxnard Health and also the medical director for the Oxnard Xavier Institute for Health Equity and Research. This morning, I will present racial disparities in COVID-19, social determinants of health equity. Learning objectives for this review is first to review the findings of racial disparities unveiled during the COVID-19 pandemic, introduce concepts of health disparity and health equity, describe the relationship between social determinants of health and health equity, and finally to define the steps to improve health equity. This slide is showing a dashboard that's available on the Louisiana Department of Health in terms of the cases that we've had in Louisiana for coronavirus since the beginning of the pandemic in March 2020 in Louisiana. And as you can see from this slide, we've had over 700,000 cases in the state and over 13,000 deaths that are attributed to COVID-19. Of those folks who are not fully vaccinated, they account currently for 89% of new cases, 84% of the deaths that are reported, and 88% of the current hospitalizations. As the graph below shows, is the pattern of our detection of COVID-19 over the course of the last 18 months or so. And as you can see more recently in August, September, we've had the highest rate of positivity since the beginning of this pandemic. Keep in mind that part of the comparison between now and in 2020, early 2020, is a reflection of the availability of community testing, which obviously is more widespread now than it was in the beginning of the pandemic. But with that being said, we've had the highest surge in the most recent months in the state of Louisiana for COVID-19 positivity. In terms of trends in Louisiana for hospitalization and ventilator usage, as you can see from this slide, the rate of hospitalizations pretty much mirror the pattern of cases positivity. So the four curves that we just reviewed. Most notably, in the most recent weeks and months, we have had the most number of people hospitalized on record, superseding what we saw in the beginning of the pandemic last year. Our rates of ventilation have also followed that same pattern. And the rates of ventilation for a while had gone down, but it seems that we currently have peaked at a rate that was similar to where we were in the beginning of the pandemic, when we knew very little about how to clinically manage a COVID-19 or what the potential outcomes of a COVID-19 infection may be. This graph is showing two pieces of information related to COVID-19 trends in vaccination by parish. And as you can see in the map on the left side, that Region 1, which corresponds to Orleans and Jefferson Parish for the most part, has the highest rate of vaccination currently at a rate of 54.2%. The Region 2 and Region 9, overlapping with Baton Rouge, also has the second highest rate of vaccination, and the rest of the state is less than 40%. In terms of trends in Louisiana and vaccination, there's been a tracking of this information by race, because very early on in the pandemic, the populations that we saw that were adversely affected with higher rates of hospitalization and deaths in the very beginning was largely Black and Brown communities. So since then, our efforts have been targeted in such a way to make sure that those populations that were seen to be most vulnerable before the vaccination was available, to make sure that we keep track of access to care and service utilization among those populations, to make sure that they were also vaccinated. As you can see from this slide, in terms of the Black population, About 29.9% of Black community population in Louisiana have been vaccinated. Keep in mind that the current demographics of the state, as far as Black or African American, is roughly 32, 33%. So we're slightly below that target population. And then in terms of populations that identify as white, we're currently at a rate of 58%, which is close to the 60% representation that we have in the state. So why does all this matter? In the beginning of the pandemic, as I mentioned before, we had seen a disproportionate impact of COVID-19 on select populations. The state of Louisiana was one of the first of 5 states to report COVID-19 cases by race. And my team were asked by our health system leaders at Oxnard to look at our data and to determine whether or not what the state was reporting, were we also seeing it within our health system, being that we're the largest health system in the state. And so with that, my team and I conducted a study looking at hospitalizations. We specifically looked at patients who had been seen in the Oxnard Health System between March 1st of 2020 and April 11th. And we're following the outcomes of individuals who had tested positive by the COVID-19 PCR. The outcomes of interest specifically were hospital admissions and mortality outcomes, since that's what was being reported in the news. And we followed this patient population through May 7th to get an early sense of the outcomes of patients that were presenting with COVID-19. The result of that work ended up showing that there were differences in hospitalization and mortality by race. And we subsequently reported this in the New England Journal of Medicine. So in the upcoming slides, I'm going to go through the details of those findings for you and the implications of what we found a year ago and the importance of those findings today. At the time, 3,481 individuals tested positive for COVID-19, among whom 70% were Black. We examined characteristics comparing Black patients to white patients and noticed that Black patients had higher rates of being publicly insured, meaning Medicaid or Medicare, living in low-income residential parts of the area, higher rates of obesity, high blood pressure, diabetes, and also higher rates of being tested in the emergency department as opposed to a primary care setting or urgent or other kind of clinical setting. Of those patients, 1,382 patients were hospitalized, among which 77% of those admissions were Black patients. A higher number of white patients at the time of the presentation had low white cell counts and platelet counts, low sodium levels, and markers of heart failure, whereas a higher proportion of Black patients presented with worsened kidney and liver function and also elevated markers of inflammation. Of note, 71% of those who died in the hospital were Black. But we specifically looked at, what's something called the case fatality rate, and that's just a raw number of how many people, the proportion of people within each race who died. And as you can see from this slide, 96 out of the 319 white patients that were admitted died in the hospital. So that's a case fatality rate of 30% versus the 22% case fatality rate among Black patients. Nonetheless, we did see a higher rate of being admitted into the ICU among Black patients, as well as a higher rate of being placed on mechanical ventilation. Notably, the length of stay did not differ in the hospital between the two populations. We further examined, what factors were associated with hospital admission, given the differences that we were seeing in the gross numbers. And our study, we looked at various characteristics, looked at the odds of admission and what was the odds of one group versus another for this outcome of admission. And as you can see from this slide, Black non-Hispanic race was associated with an approximate 2-fold increase in the odds of admission. And additional factors that were associated with increased odds of admission included age, public insurance, living in low-income areas and having a medical history of obesity. We further looked for what were the risk factors for in-hospital mortality and discovered, as this slide shows, that the risk did not differ by race. After adjusting for sociodemographic and clinical characteristics, in-hospital death did not differ between the Black and white populations. Instead, strong factors included age, the respiratory breathing rate at presentation, signs of organ damage, inflammatory markers, or low blood counts at the time of initial presentation. So, in our conclusion, it wasn't race that was a significant factor for in-hospital death. And most often when I report this, most people say, how is that possible? You just said most of the people who were infected were Black. Most of the people who were hospitalized were Black. Most of the people in critical care on ventilators were Black. Most of the people who died were Black. How is it not a factor? And what I explain is that based on our analysis, race is a social proxy for other factors that increase the risk of exposure, infection, and vulnerability to COVID-19. There were sociodemographics, of at-risk populations that we saw admitted to the hospital that were explained in our analysis. There's also a question of economic vulnerability, a hint of which comes from the public insurance coverage. Disparities in the prevalence of underlying chronic conditions, which we saw in the sample of patients who tested positive. And then a question of probably, are there differences in access to care or delay in receipt of care, since we saw that a high proportion of Black patients actually were tested at the point of admission or through the emergency department as opposed to a clinic. We further did some additional studies thereafter, a couple of months into the summer, past the time period of this initial study, and examined racial and workplace disparities in the seroprevalence in the Baton Rouge area and also the New Orleans area. But for the sake of this presentation, I'm only presenting the Baton Rouge information. On this slide, we present information in terms of the odds of testing positive based on a variety of different demographics. And by positive, we have different categories of that. So a new infection, you would test positive on the PCR. You're still replicating the virus. Late stage, you may now have antigens presenting, and that's another rapid test that came along later in the repertoire of testing that we had for the community. And then finally, past infection is reflected by whether or not you have circulating antibodies in your system. And so for the sake of simplicity, let's look at the plot that's looking at any positive test. The rate, or the odds, I should say, of testing positive was higher or significantly higher in Blacks compared to white non-Hispanics, also in Hispanics versus non-Hispanics. And then younger populations under the age of 40 had a higher odd of testing positive. Additionally, we looked at marital status, work environment, and the type of work that you do. And those who were single had a higher odds of being positive compared to those who were married. People who had to completely go into work as opposed to working from home, part-time or full-time, also had a higher rate. If you had a public-facing job versus an office job, a delivery driver, which is public-facing versus an office job, if you worked in the healthcare system, regardless of whether or not you had direct patient care, anything other than working in an office, you had a higher rate of, or higher odds of testing positive. So what's the significance of all of that? A lot of those positions that were not office-based, did not have the luxury of working from home, or what we all became familiar with as the essential worker. Essential workers are at a higher risk of exposure, and because of the public-facing nature of their job. Of note, in the state of Louisiana, the percent of essential workers who earn less than $30,000 annually by race and sex, higher proportion of those workers are female and persons of color. All of those positions I just mentioned in our previous seroprevalence study compared to office workers are examples of those essential workers. And as you can see from that study, had a higher odds of being positive. So there was something about the risk of exposure of a segment of the population that disproportionately was represented by women and by persons of color. Additionally, we saw the differences in underlying chronic conditions by race in our study sample. But I want to point out that in Louisiana, we have a longstanding history of health disparities that has been well documented in our annual health reports, whereby information on chronic conditions is stratified by race or ethnicity, sex, level of education, household income, health insurance type, all of which are known as social determinants of health. All of these factors weigh heavily on our health rankings as a state. And for a long time, we have been either 49th or 50th. In 2020, our rank dropped down to the 50th. There's only one other state that we compete with. But as you can see from the American Health Rankings, there are various components that contribute to that. And those for which we have the lowest ratings all overlap with dimensions of social determinants of health. So social, economic, physical environment, behaviors, those sorts of things. We know that social determinants of health drive most of health outcomes. Only 20% of health outcomes are due to clinical care. So care that I and my colleagues provide. The other 80% is related to environmental, socioeconomic, and health behaviors. And as this slide shows on the right side, I have listed the top 20 drivers of Louisiana's poor health rankings. Those 6 items that are highlighted in blue are social determinants of health. And as you can see, these things have weighed very heavily in our current rankings. So to level set on definitions, what do we mean by social determinants of health? The World Health Organization defines it as conditions in which people are born, grow, live, work, and age. These are circumstances that are shaped by a distribution of money, power, and resources at global, national, and local levels. The social determinants of health are mostly responsible for the health inequities that we see. In other words, the unfair, avoidable differences in health status seen within and between states and across countries. Health disparities is defined by Healthy People 2020 as health difference that's closely linked to economic, social, and environmental disadvantage. Adversely affected groups, it's not just a matter of race and ethnicity, but there are social and economic obstacles that can be based also on religion, socioeconomic status, gender identity or sexual orientation, mental health, cognitive, sensory, or physical disability, geographic location, such as rural versus urban, and other characteristics that have been historically linked to discrimination or exclusions of subpopulations. Healthcare disparities was defined in 2002 in a report by the Institute of Medicine called Unequal Treatment, whereby it's defined as differences in the quality in healthcare that are not due to access-related factors or clinical needs, preferences, or appropriateness of the interventions. Healthcare disparities is a subset of the broader concept of health disparities. That brings us to another term, health equity. So to pause, let's look at the pictures on the right side of the slide, which is a way of trying to understand the difference between equality and equity, and then more importantly, what we mean by justice. And so as the slide shows, equality is not the same as equity. Ultimately, we're striving for justice. In equality, you have people who may be of the same height, and you give them the same box to stand on, but the ground that they're standing on is not even, and therefore they're not on a level playing field. Equity says, okay, leave the ground the way it is, the differences at each level. Let's give them boxes to stand on where they're at equal height at this, on standing on the boxes. That's equity. Justice says, Hey, let's take away all those barriers that's creating the differences in access to each of the different individuals and put them on the level ground so that they have an equal opportunity. So this top picture is one way of portraying that. And I added the bottom picture because I like the idea of explaining the difference between the realities that we experience right now with social determinants of health and there being inequities in access to various things. The same concept in terms of equality versus equity. And these are kids that are trying to watch a baseball game over a fence. But the concept of justice or liberation means that you remove that barrier so that you don't have to stand on a box in order to see the game. So I just wanted to make sure we were clear on the difference in terminologies that fall into this definition to understand health equity. So the Robert Wood Johnson Foundation defines health equity as meaning everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles such as health, such as poverty, discrimination, and their consequences. Health equity is an ethical and human rights principle motivating efforts to eliminate health disparities. This is the World Health Organization's conceptual framework for action on social determinants of health that sort of puts all this stuff together in a visual way. On the left side of the framework are the structural determinants. And by that, we are born into social classes, a gender, ethnicity that is linked into socioeconomic position within our society. That classification also has implications for your access to education, future occupation, and therefore future household income. But being placed into those groups is a product and related to a larger socioeconomic political context that governs our condition. Those are what we mean. That's what we mean by structural determinants. But those things then impact your material circumstances. So your living and working conditions, your access to food, walkability of your neighborhood, your health behaviors and other biological factors, and also psychosocial factors like financial strain related to the kind of work you do or your material circumstances. Note that the health system is downstream of all these things. And so as a healthcare provider, we can either mitigate the impact of social determinants of health, or we can worsen them in terms of the impact they have on equity and health and well-being. And so this is a framework that I often refer to sort of understand a larger context of how all this stuff is connected and what is it that we're seeing and why are there differences between different populations that often are stratified by social class, gender, ethnicity, and other areas in which people are systematically discriminated against. So I wanted to show you how that translates in today. This is a map of the greater New Orleans area. And this particular map is looking at rates of poverty by census block. So the darker the purple, the higher the concentration of poverty greater than 40%. So you can see from this map that there are certain areas where there's really dark purple, more like it probably would be qualified as inner city. If we look at the overlap of areas where the population 25 years and older has less than high school education, you can see that there's some similar pattern in terms of the darkness of the purple, a little bit more expansive now. If we look at households where the percent of workers earn less than $1,200 per month by census block, again, you can see a similar pattern of distribution. The darker the purple, the higher the rates of low wages. Similarly, if you look at households where renters are paying greater than 30% of their income, again, there's a similar pattern to low education, high rates of poverty that we previously reviewed. Here is looking at multi-generational households, so the percent of children that are living with grandparents. And again, there's a similar pattern that we saw in the previous maps. Public transportation, the darker the purple, the higher percent of workers who have to take public transportation. Now look at the map by the New Orleans census block data by race. And in this map, Where you see the blue, those are majority Black household. And where you see green, those are majority white households. So if you recall the patterns of deep purple, a lot of those social determinants that the map is displaying overlaps with households where you have majority Black individuals in the neighborhood, in the home. So how did we get to this place? Historically, it's important to understand the political context or the structures that were in place policy-wise that led to housing discrimination and the downstream consequences of housing segregation. In 1934, there was a National Housing Act, which was a systematic denial of various services by federal agencies, local governments, or the private sector, whereby prices were selectively raised to discourage banking and mortgage lending and insurance to certain populations. The Homeowners Loan Corporation actually had a process in place of grading neighborhoods into categories based on a large part on the racial makeup, whereby neighborhoods with minority occupants were marked in red. So when you hear the term redlining, that's where it comes from. It's referencing this particular practice. In 1968, there was the Fair Housing Act that said it was illegal to discriminate on the basis of race, color, religion, sex, disability, familial status, national origin when it comes to mortgage lending, that you could not use those as reasons to refuse to lend or to provide financial assistance for a dwelling or to provide information regarding loans or different terms or conditions of those loans or differences in the appraisal of the dwellings. So this is what redlining looked like back in the 1930s under the New Deal. So I'm going to show you some historical maps. And if you'll notice, it's the greater New Orleans area that looks very similar to the more recent maps that I just displayed in purple. But of note, areas where it's marked red are considered hazardous for lending. Yellow indicates that the neighborhood is declining. Blue is still desirable, but your green areas are the best areas to lend and provide services. So this is a close-up of part of the New Orleans area. The area in blue that you see on this map is surrounding Tulane University, Audubon Park, and Loyola. So if you're familiar with that area, that's this area near the historic part of town with the St. Charles Avenue and the streetcars. This slide is showing you details of what goes into a neighborhood being labeled blue. And if you look in the red box on the left, you'll see that the classification is based on occupations. So most people are middle to high class, executives, business and professionals, 0% nationalities, 0% Black, and there's no threat of the population shifting. So that's a good neighborhood to invest in. Down the street, the yellow neighborhood, yellow blocks have middle to high class executives. However, there are 5% folks that speak French, no Black occupants, but there's a gradual infiltration of low income groups. The red neighborhood, or block, I should say, all have a lot of African Americans, common laborers, low wage workers, mechanical people who work in mechanics or domestic workers, 90% Black, no shift or infiltration, but bottom line is those characteristics get the census block labeled as not desirable. What are the implications of something from the 30s till now? This is a map of the New Orleans market value in 2016 and 2017, where you can see the median home sale prices of homes. The darker the brown, right, that's the higher median sale value of the property. And then obviously the more yellow, the lower the value. If you will recall the maps of where Black households are and white households are historically in New Orleans, you'll see that most of the neighborhoods where you have white majority households have a higher median sale value. The implication of that is that there's less mortgage capital in lower valued neighborhoods, lower rates of home ownership and generational wealth, Because of the property tax being a funding source for public schools, you have less funding, decreased medical and social services, food deserts, less green space, and less walkability. So policies that were put into place in the 1930s have a legacy as far down into the 2000s that are consistent with patterns of racial segregation of housing and all the implications that go along with that. So this is a concrete example of how social determinants of health has an impact on patients or individuals' experience and their work and living conditions and the implications that it may have for health. So our pathway to equity, we must focus on social determinants of health with a heavy focus on ensuring that we have economic stability across populations, improving our social and community environment, creating access to high quality education, improving the neighborhood and built environment, and improving health and healthcare access. We must commit to identification and elimination of these disparities, but first and foremost, that requires that we link our quality improvement efforts to equity and understand that the two are connected. We have to create within our organizations a culture of equity, but that starts with diagnosing disparities that exist within the populations that we serve or services that we provide that may be contributing to disparities. And that's where data and understanding how you're performing and whatever it is that your field of specialty is and whoever you're serving, you have to focus on gathering the right data to understand whether or not there's disparities among the population you serve in the spectrum of the work that you do. In looking at that data, that helps you discover innovations or think of innovatively about how you can address disparities within the scope, of the work that you do and design the appropriate activities to reduce those disparities and therefore improve health equity. But this requires a huge amount of change management. And first and foremost, we have to start with securing buy-in of those stakeholders who are impactful on the work that we do in one way or the other, and then focus on what it takes to implement those changes in order for us to execute the innovations that we feel would help us get more closely towards health equity. From Oxnard's perspective, we have committed to being a part of a solution with the state over the next 10 years to do our part in ending health disparities. And that requires that we go outside of the four walls of our system, understanding that we're downstream from a lot of structural barriers and other things that are in place that we can either mitigate or make worse. We have to go outside of our institution and partner with state government and other entities in order to move towards a strategy of overall improvement in the community health, and that the basis of that is doing this work through the lens of health equity. With that in mind, we have formed the Oxnard Xavier Institute for Health Equity and Research in collaboration with Xavier University of Louisiana. It made perfect sense for us as a health system to partner with an entity that's already been in the space for social justice. There are many things that we have been doing together as it relates to clinical training, but there are a lot more things that we can do to leverage both institutions to move upstream of the healthcare system and out into other realms that are associated with the social determinants of health. That requires coalition building. It requires working on policy and strategic partnerships in the areas to improve social equities and institutional equities. It requires focusing efforts around infrastructure development to improve living conditions, health education, and other activities that will promote healthy behaviors, all of which combined has an impact on health outcomes and the health interventions that we design. There is a lot of work to be done. We are at the beginning of this process, but I say all this to say that in order for us to improve the health of the state, reduce the disparities, reduce the vulnerabilities that we have seen that have led to differences in outcomes in COVID-19, We have to do all of this work with a lens of health equity, and that requires a fundamental understanding of what we mean by disparities versus health equity. Disparities is a measure of how far or close you are to health equity. Health equity is what are you doing to provide a solution to the problem? And it's important for us to be solution oriented through the lens of health equity. And with that, I will end my presentation. And I want to leave you with words that are very meaningful to me from Ruth Bader Ginsburg, which is fight for the things that you care about, but do it in a way that will lead others to join you. The work that you're doing, the work that we're all doing is very important and meaningful. And there are people who may not understand the context of what we're talking about or the lens through which we see what we do. But if we fight for the things that we believe and bring people along in a way that engages them in this conversation that can be very difficult if you don't have the knowledge or the background or the experience, the lived experience specifically for some of the things that I talked about today. But I implore you to pick up the torch and to continue this work. I appreciate all that you do. Thank you.